is slightly more specialized, but I think it becomes very important when we think about maternal mortality rates. I don't have any PowerPoint presentations, neither I have any case scenarios, because I thought we should talk about issues in critical care for obstetrics, which is a bit of a gray area still in India. We have 5 panelists with us. Can I invite Dr. Stephen Guyatt to please come to the podium? You've all seen him, heard him. Let us give him a hand. We have been told all the good things about him, something very great. But just now he's told me he was responsible for setting up the first intensive care unit in Australia. Right, sir? I think it will be great to have you here. Then I would like to invite Dr. Y.K. Chan from Malaysia. She's a professor of anesthesia, University of Malaya Medical Center, KL. She has edited a couple of books in acute care, has about 36 papers in major journals besides numerous workshops, seminars and conferences. She was the president of the Malaysian Society of Anesthesiologists and College of Anesthesia. She is presently the vice president of Obstetric Anesthesia Society of Asia and Oceania since 1989. She was a member of various medical associations behind being on the editorial board of many journals. She's on the board of our journal too. And Dr. Guyatt is also on the board of our journal. She's the chairperson of Malaysian Society of Anesthesiologists from 2010. Let us all give her a hand, please. Thereafter, I invite the Vice President of Association of Obstetric Anesthesia, Dr. Prithvis Bhattacharya. Each one of us knows him. Our society wouldn't have been up and about. It wouldn't have had a bank account. It wouldn't have any money in the bank if it was not because of him. He's done a great job as far as the society is concerned. We had a tough time registering our society anywhere, but he took the lead. He's a Vice President with us, and let's give him a hand, please. Then we have with us Dr. Srinivas Samavedam. Please. He is Chief Intensivist, Care Group of Hospitals based in Hyderabad, and he is the intensive care man with us. Let's give him a hand, please. Lastly, we have Dr. Pankaj Kundra. I'm sure each one of you who has been in India in anesthesia knows him. He could come here and stand and talk about a lot of things, and we would all be awake. We would be interested. He's an excellent speaker, has excellent knowledge about the subject, and presently he works as a professor of anesthesia, JIPMER. He's a teacher par excellence, recipient of a couple of WHO fellowships in intensive care and pain, and also a fellowship in application of ultrasound in anesthesia. He has delivered more than 100 guest lectures, has about 52 publications in peer-reviewed international and national journals, 2 chapters in book, and his areas of interest are regional anesthesia, airway management, and pain therapy. Let us give him a hand, please. Okay, so let's start immediately. The basic idea of having a panel discussion and not a PowerPoint presentation and a 30-minute dedicated lecture on this was because we wanted each one of you to interact with us, each one of you who are into care of obstetric patients who are sick. Maybe you don't have an ICU at your hospitals dedicated to this group of patients, but maybe you have HDUs. I'm sure people would have HDUs in their hospitals where you manage sicker patients. Okay? I would want you to ask as many questions as possible. Our panelists are here to answer all of them. And it's not really important how absurd a question is, as long as you think it's going to help in decreasing the maternal mortality rate and taking care of a pregnant woman. The first question I put forward to my panelists, and I would put it to Dr. Chan. Could you tell us what are the common causes of ICU admission in your setup, ma'am?
Actually, the common causes of ICU admission very closely reflect common causes of maternal death as well in, I think, throughout the world. If you look at the common causes of death, in fact, whether you come from a developing or developed country, it is actually fairly similar in the sense that the 3 big killers are obstetric hemorrhage, pulmonary embolism, and preeclampsia. And you will find that actually whether it's in the developed or developing countries, they are either the top 3, the top, part of the top 4, they are actually fairly similar. And even if you look at the developed countries, over the years, they actually hang around the top 3 and top 4. But the thing is, the maternal database, mortality database, only reflect the tip of the iceberg. So the bottom part of the iceberg actually will be represented in all the ICU admissions. And it will be actually fairly similar to what is represented in a maternal mortality database. So your ICU admissions, most of the time, actually parallels that kind of
Okay,
pattern
so
as well.
now we know from Chan that there would be basically 3 conditions, and this is as per as your country is concerned,
Yeah, but of course,
which could be, we could label your country as a developed country or a developing country.
we are still developing.
Developing country like
Yes.
ours. Okay, that's good.
But the other diseases like cardiac disease in pregnancy is also becoming quite a feature, because a lot of mothers actually with cardiac problems, now with better care, they're actually all becoming, they've come to the time where actually they are fertile and they are able to deliver. So that is this category of patients who are also presenting for care and who subsequently also need ICU admission.
Okay, I would come down to the audience now. Does anybody want to comment upon the kind of patients who come to their HDUs or ICUs who are pregnant or after deliveries? Right? Do you want to comment, sir? No, okay. Anybody who wants to comment?
Can I make a comment first? I think a lot of what comes into your intensive care unit depends on what sort of intensive care unit you have. In general, and if you look at almost all countries, from Israel to Brazil to about 2% of a general intensive care actually are obstetric patients. So it's not a very high proportion overall. And if you have that type of intensive care, most of the patients that are going into intensive care are people who need ventilation or people who have post-surgical disasters, at least for a few days. So that's one type of intensive care. On the other hand, if you have your own dedicated obstetric care unit, it depends on what your women's hospital looks like in the first place. In my case, for example, when we set up this thing in 1987, it was an obstetric intensive care, it's true, but it was within the context of an obstetric and gynae hospital. And our patients, I think, were grouped into 3. You had your gynae patients that were the usual post-surgical disasters. You had a 1/3 of the patients were gynae oncology, and 1/3 of the patients were obstetrics patients. As YK has just told you, it is very true that in that 1/3 of obstetric patients, the distributions are very much, in our case, massive hemorrhage, coming to intensive care, preeclampsia for management, especially the ones that had eclampsia already. Then there were a sort of small subgroup of that again with the HELP syndromes and so on. And then finally you had the occasional sepsis in there that needed management. And those were the chief groups. And on top of that, you then had your thromboembolisms. Now your thromboembolisms, in our case, often get exported out very quickly because they would go to a stroke unit or go to a high, go on for ventilation, long-term ventilation and so on. So a bit in how you structure your intensive care in the first place will determine what your number of admissions is. It also determines your mortality and morbidity inside the intensive care unit.
Right, so we come to maternal mortality in ICU after a minute. I couldn't see you. I would like to invite Dr. Tarakeshwari, who is our obstetric medicine expert, HOD. Sorry, ma'am, I couldn't spot you at that time. And she's from Fernandez Group of Hospitals. And we were talking about you because Dr. Gatt was very much interested to know who our obstetric medicine chap is. And he thinks that obstetric medicine people are really gone above the board nowadays in Australia at least. We have a comment from, yes ma'am.
In our part of the country, I think even malaria is one of the very leading cause of admission in
Yes. The issue is that the patient profile will be different. We still see a lot of rheumatic heart disease. I'm sure Prithvis or Pankaj could, or even, Srinivas could tell us. What do you think in these 3 different states? Prithvis comes from Assam, slightly more backward, nothing against that, but we could have a lot of patients with malaria, dengue fever, or any kind of tropical diseases. There would be a difference in the patient profile. Yes, Prithvis.
We get a very heavy load of malaria patients, cerebral malaria patients coming in. We also have severe anemia leading to cardiac failure under these conditions, and they come in. And the sepsis untreated or maltreated, culminating in sepsis, shock, septic shock or severe sepsis coming in. Besides the cases we discussed about hemorrhage, etc., these three are a very big group. And of course, we get the occasional cardiac patients who have come in.
Pankaj, what do you think about rheumatic heart disease? You think you still see a lot of rheumatic heart disease, pregnancy coming into failure and after seizure, before a seizure, or admitted into your hospital and coming into ICUs?
Yeah, precisely. I mean, there is still, the incidence has not come down. And
Sorry, it has not come down.
It's not come down because what happens is the hospitals, the tertiary care hospitals, which caters to the poor patient population or the rural patient population, where the women are actually transported on bullock carts to the hospital here. Those lower socioeconomic group people who cannot afford treatment elsewhere in private hospitals land up at tertiary care hospitals, and you have a vast load of them. And every day, when we do a puerperal sterilization, we have at least 2 cases of valvular heart diseases which will be undergoing a PS every day. But a recent trend which we have seen, surprisingly, is that generally the PS cases which we do not work them up too well because they would have normally delivered. And the policy is to give a spinal to them. And you have about 10 cases which have to be done in a span of 3 hours. We have had 2 unanticipated cardiac arrests in the post-op ward. And the reason we found was later that the patients had peripartum cardiomyopathy. This is one condition which is uprising, and these are one group of patients which we are likely to miss, and unless we otherwise examine them properly, and they are occupying the ICU beds nowadays.
So I think where we've come down now is there's a different patient profile which comes to us. And what I think is, like what Pankaj said, you work in a public government hospital, the patient profile will be different. You work in a top-line corporate hospital, and the patient profile will be different. Maybe you have no rheumatic heart disease. I also think in my hospital, which is a tertiary care hospital, most of the times the patients who come to the ICU come with rheumatic heart disease, cardiomyopathy, corrected congenital heart diseases, or uncorrected. Cyanotic heart disease, uncorrected. They have been trying their best to tell the lady, you don't have a child, but he still has a child. Tetralogy of fellow, she comes with us, and we had a tough time. I would ask you now, in your corporate hospital, what is the patient profile?
The actual number of obstetric patients who do come to the tertiary care ICU where I work is about 0.5% of our annual admissions over last year. This is from last year's statistics. But I agree with Dr. Stephen Gadd, who said, what is the type of ICU you run that determines your intake? Our hospital being a specialized cardiac care center initially, we get a lot of these referrals for peripartum cardiomyopathy, pulmonary thromboembolism, and other valvular heart diseases, as you mentioned. But over the last year or so, we have found infections complicating pregnancy, dominating the demographics of patients coming into the ICU, not discounting the fact that the H1N1 pandemic seemed to have hit the peripartum and antenatal patients more than the general population. Infections complicating pregnancy would be first, and heart diseases. But also, I would like to make a mention that because we have a very active extracorporeal service, plasmapheresis and other techniques, a lot of these patients with hemolytic uremic syndrome and thrombotic thrombocytopenic purpura and HELLP syndromes are referred to our hospital for this kind of extracorporeal support. So that is our spectrum.
That would be tertiary care, this thing.
Tertiary, yeah.
Now, I think we finished cardiomyopathy here. Stephen.
Before you go on to cardiac, we're seeing a tremendous bias currently, a skew of the types of cardiac patients that we're seeing. We see hardly any valvular heart disease anymore. Almost all of them have had surgery, and so we don't see a lot of valvular heart disease. We see a fair bit of PPCM and other forms of cardiomyopathy, especially the cardiomyopathies that are being diagnosed more and more frequently with the use of cardiac ultrasound and tracheoesophageal esophageal imaging. But the other thing that we're seeing quite a bit of is the disastrous cases of people, for example, with severe pulmonary hypertension who have managed to get themselves pregnant. And so we're seeing those very severely sick patients who often survive the delivery, often survive the tubal ligation afterwards, and then go home and die 6 weeks later of the severe pulmonary hypertension. And this is becoming a great worry to us in a lot of ways. I once asked Michael de Sweet what we should do with these patients. He says, give them the following advice. If you're pregnant and if you've got pulmonary hypertension, don't have sex. If you have sex, don't get pregnant. If you get pregnant, don't have a child. If you have a child, then don't come and ask me what to do about it. You know, and that's in fact quite good advice, you know, because really with these, we're getting a lot of these patients who are virtually terminal in terms of the pulmonary hypertension. You know that over the next 5 years it's going to progress even further, and there's nothing much you can do about treating them by giving them, for example, a heart-lung transplantation, which is available. But what I'm saying is there's a great skew in the heart disease in some countries. I'm sure you're not seeing this yet, but you will eventually.
Right. We think we will, but okay, fine. But the advice which somebody gave you, those 5 sentences, I think we could take it for the whole country. Don't have this, don't have that, but if you have this and that, don't come to us. Yes.
You know, just to stretch the pulmonary hypertension part of it, most of us, I believe, are anesthesiologists, so we don't really have much to say or to do with these patients. But, you know, most of the time, by the time they come to us, they're heavily pregnant, or they've come at a time where, you know, things cannot be reversed. So I think the person to educate would be the cardiologist, because I think a lot of cardiologists do not know the significance of pulmonary hypertension and pregnancy and the mortality that comes along with it. Because I personally had one patient who actually came in with pulmonary hypertension at about 20 weeks, and, you know, we had to actually terminate her pregnancy. But, you know, we actually asked her her history, and she said she was told 3 years ago when she had another termination that if everything goes well, she can become pregnant at the end of 3 years. And she faithfully followed the instructions of that particular doctor. She became pregnant, and she came in for that current pregnancy, which ultimately killed her. So the thing is, who can reach this particular patient and reverse that course? Not us, not the anesthesiologist, but the cardiologist. So I think we should tell the cardiologist this important fact.
I think, thank you very much. If you were there in the morning, in the first session, somebody was talking about teaching anesthesia to obstetricians. Now we have somebody who advocates teaching anesthesia to cardiologists. I don't know where we go from this. Very soon the obstetricians are going to tell us, why don't you learn how to do a PV and see what's the dilatation, then you can put your epidurals. Don't call us, what centimeters, I don't want to do this, I don't want to do that. Be self-sufficient and have a closed epidural service unit. Thank you very much. After the patient profile, we come to a very important question, and I put it to Stephen again. What prompted you? Did you got the money? Did the government tell you, or you were interested to set up a dedicated ICU for pregnant patients? Were they paying you a lot of money for that?
There's a very simple answer to all of this, and this is to do with geography mainly.
Okay.
At the time, the Royal Hospital for Women was a freestanding hospital that didn't have an intensive care. Every patient who was an intensive care patient theoretically was going to be shipped out. We'd already started to take care of them in a special area if they were sick. And suddenly the issue became, look, you guys are going to need to move from here and go somewhere else because you don't have an intensive care unit. When I did the sums, it was actually very few patients that we sent across. We actually sent about 39 patients out of hospital that were obstetrics, and most of them were going to a nice place for convalescence afterwards. A couple of them were psychiatric patients that had postnatal depression and required to go to a psychiatric unit. So really, there was probably about 10 patients a year that we were moving. But the excuse from the government was that because we didn't have an intensive care unit, we're going to move you. So we said, that's not a problem. We'll build an intensive care unit. And so then the issue became, how do you design an intensive care unit that is obstetric specific? And it was a lovely exercise in many ways, because those days there wasn't even an obstetric medicine unit in our hospital. We didn't have physicians. So basically the anesthesiologists and the intensivists took care of all the sick obstetric patients. So really it was geography and politics that drove it in the first place. But in the end, it was probably what saved us for 20 years from having to move onto the current site, Prince of Wales, which has not one intensive care unit, but has about 6 or 7 intensive care units. They've got a PICU, a SICU, a FICU, a RICU, and a NICU. And they've got all sorts of ICUs, But what I'm saying is that having an obstetric intensive care unit has remained. We call it the acute care center currently, and basically all the obstetric units, all the obstetric patients are taken care of over there first before going to the ICU. And the rules now are quite simple, really. If you need to ventilate for more than 2 days, for example, then we move them to the major intensive care. But in the main, the bulk of our patients are taken care of in the obstetric intensive care. I think this is very important because I think intensivists, with all due respect, do things very, very well for intensive care patients, but they don't understand obstetrics at all. And the obstetricians themselves are absolutely petrified of going down to the intensive care unit. So once they go to intensive care, it's abandoned ships from the obstetricians, it's abandoned ship from everybody else except 2 groups of people, us and the obstetric medicine specialists now. So things have improved since those days, but that was the reason why we set up the unit.
Right. So there was some politics, there was some geography, and you really felt need of it. Do you think you did the right job, or you repented, or you want to open more of these ICUs?
It doesn't matter what I think. It's more important what A, the mothers think, and B, the hospital administrators think. It did what it was meant to do. It saved the hospital from being moved for almost 20 years. It was very good care, and suddenly the hospital, this is what I like to call the Nigeria experience. If you have a hospital, even if it's very run down, if you buy yourself an MRI machine, it suddenly becomes the best hospital in the world, you know what I mean? Because that's the best that's over there.
Right.
And we became very much like this. We suddenly became the Nigeria experience, Suddenly we had the best obstetric and the only obstetric unit in the country, and so it became very popular for dealing with obstetric patients.
Okay, right. Now, Prithvis comes from a hospital which is just about 5, 7, 8 years old. It's one of the newest public hospital in the country. It was just built about 8 years ago, and staffing and the equipment came later on. You thought there was a need, heading the Department of Anesthesia, Intensive Care, you thought there was a need to have some dedicated space for obstetric patients, Prithvis?
Well, actually, by the very nature, if we are talking of a pure obstetric unit, then you are supposed to have the facilities for delivery also nearby. Now, that is not a very feasible thing in most of even the premier institutes and even the corporate sector, because the money invested would be very high. But what happens is that the obstetrician doesn't get time to come to the ICU. And when the intensivist goes to the obstetric ICU, if we set up one in our country, in any place, the number of patients in that hospital actually needing intensive care from the obstetric population is going to be very low. And the intensivist will lose skills. And actually the obstetricians neither have the time nor the inclination, and they would also not be gaining much skills. But if in the intensive care unit, you make it a policy that whenever the patient is coming, at least one of their doctors keeps coming on a regular basis, and one of their juniors, like a junior resident or a senior resident, is attached to the ICU for the duration of the patient's stay. The skills are developed without the person wasting his time doing nothing when there are no patients. And the anesthetists also are learning from the obstetrician at that time, because most of the anesthetists also have to be very familiar with whether it is cardiotocography and echocardiography. All these things, they have to be working together. And in this type of setup, if the junior from the obstetric unit is seconded to the ICU for the duration of the patient's stay, optimal utilization of training and exposure time will occur. And the anesthetist also will not be left floundering with taking obstetric decisions which cannot wait.
See, in a hospital like ours is a public hospital. We can afford to have a medical intensive care unit, neurosurgical intensive care unit, cardiac surgical intensive care unit, separate intensive care units. We can afford to have, because it's the municipality or the government which is funding, and they usually we have many isolated intensive care units. But if you look at the corporate hospitals, I'm sure they are not going to put all their money in various intensive care units, including an obstetric intensive care unit. So every patient who needs intensive care will be coming into one common intensive care unit.
Okay.
So
that sounds more
Can
logical.
I make a comment on that?
Right.
Because one of the main things, purposes that are served by at least 2 or 4 obstetric care units in our country would be to serve as a teaching and training center. Otherwise, as such, the value for money or the efficacy for the money spent would not be very high, but it would serve as a very good teaching and training center.
Pankaj, what do you do at yours? I'll come back to you, sir. What do you do at your place? The same like she said?
No, it's high dependency unit. So if the patients are shifted into the HDU, we will be doing a remote control management of those patients. So it is easy for us to shift them to the ICU and manage them.
So that sounds more logical, that you shift the patient to your main unit where you have enough staffing and nursing. Yes, sir.
I've seen a very ingenious solution to this problem, and it happened to us when they moved the women's hospital, expanded the children's hospital onto the one site. And I've shown you the pictures this morning of what the hospital looks like. And they came up with this concept of what was known as the hot floor. There is one floor that runs through all the hospitals, basically, that has all the hot services. Hot services are operating theaters, labor and delivery suites, intensive care units, children's intensive care, nurseries, and so on. They're all on the one floor. In an architectural sense, this made a lot of sense because it meant that you could have all your gases, all your driving gases for ventilators and so on, all your electricals, everything else, all sitting on one level, and the rest was all patient accommodation. So really, in many ways, this was a very wonderful situation to be in, where everybody got their own little intensive care units and whatever they wanted. They were all placed next to each other, and away often from their own units, but they then had one area that was dedicated on the hot floor. And of course, the women's hospital were put next to the women's hospital, the children's hospital had their own, but they were still all on the hot floor, which made a lot of sense from the utilization of your intensivists, a lot of sense from utilization of your resident staff. And we're a public hospital, basically, on that entire floor. So essentially, public hospital has everything, including its cardiac theaters, its cardiac intensive care units, and so on. So I think that there is a solution to the Mumbai situation where, sure, you want to have one intensive care unit, if possible, but then again, expertise for stroke units, for example, is different to the expertise you require for coronary care.
Right.
So I think that's a solution, perhaps, that might apply to you as well.
Okay. If we have a pregnant patient in ICU, could be ventilated or may not be ventilated, let's say 30 weeks pregnancy, what kind of fetal monitoring you think is required? If I decide to accept this patient, what should I have on board before I really accept this patient and ventilate her?
I would like to first know the gestational age of the baby.
I said about 30 weeks pregnant.
30 weeks pregnant, and initial assessment of the baby, if the fetal growth is adequate and the Leica is fine and the Doppler study shows no growth restriction, that means this lady had no underlying chronic medical problem and the baby is doing fine. I would love to give her steroids and monitor the baby. Suppose the mother is in a situation where a delivery is warranted. Like I'm fortunate to have the group of Perana and a physician. So they tell me, ma'am, this is going to be like this in another few days or 4 days or 1 week. What is your plan? So I write off the plan there. I assess the basic assessment. I do a cardiotocography. I look at the age and the weight of the baby, and I see again tomorrow. Suppose it's a Doppler abnormality, I do morning and evening CTGs. And suppose it warrants 48 hours and I say, okay, no, this baby will not be able to make it. We need to deliver this mother so that the baby is better in the ICU. Because our survival is like 28 weeker, 26 at times go for those IVF mothers. Otherwise 28 weekers, 1 kg, they do good. So it's the risk which we have to decide. It's a benefit whether to bring the baby out and then put in the ICU, NICU or not. So the monitoring is basically the ultrasound, the CTG.
Okay, what I wanted to know was, do you monitor fetal heart the way you would monitor a lady's heart continuously or intermittently, or what do you want us to do in an ICU?
It's not viable for us continuous, sir. Very few situations where continuous. Otherwise, it's an intermittent cardiotocography which we do, the CTGs, NST we do. Sometimes we ask once in 4 hours, once in second hourly. It depends upon the situation.
What happens in the care group of hospitals? Do you have a dedicated obstetric medicine chap in your ICU whom you can call?
No, we don't have an obstetric medicine specialist available in the hospital, but our in-house obstetricians are always on site. These patients are actually looked after by the intensivists who are on site 24/7. We do not have a dedicated obstetric intensive care unit as yet. As was discussed, yes, it would make sense in having a separate dedicated unit, but a corporate hospital will always look at financial viability. So that's one of the issues. But I would like to add to what discussion I thought I would say. 70% of the success of an intensive care unit is from the nursing staff. And you need to have a very, very good understanding of what monitoring a patient would require. From that point of view, a neuro-intensive care patient's requirements, a transplant intensive care patient's requirements, and a post-cardiac surgery patient's requirements, and so also an obstetric intensive care patient's requirements are totally different. If you mix all these patients in one ICU, your nursing staff, at least in this part of the world, given the level of training and their ability to grasp things, with no disrespect to anybody, you are going to confuse them. So it's better to have a dedicated training program, organ-specific wise, and train them in every aspect of intensive, this kind of intensive care, and put dedicated nurses. That's
okay, coming to nurses, I think I finished the nurses thing here.
Yeah.
What I think and what I gather from the national scene is, if you have a trained nurse in an intensive care unit, no matter if it is coronary care, cardiac care, any kind of care, and he or she is good at it, within 3 years, off they go to Australia or USA. And Stephen is very happy. He has excellent nurses who from this part of the world, but then we feel very sorry about them because all the good
They're all
ones
from
are there.
Kerala.
Right. The official language in certain hospitals in UK after 6 ill is any of the Indian official state languages. Right, it is because most of them are from Kerala. I think we have to put a ban somewhere there about, and I'm sure Pankaj would agree with me, anybody who is good at his job in nursing care, especially in an ICU, within 3 years comes up with 3 forms, some testimonials, and you say, fine, you've got better money, better place, or whatever you do.
Well, it's very interesting because I think a very important point has been made. When you build a new obstetric intensive care unit, and as I said earlier on that we had oncology patients and so on, I think it's very important that you employ the right nurses for an obstetric intensive care unit. In our case, they were 1/3 midwives, 1/3 intensive care nurses, and 1/3 were oncology nurses. The beauty of it was that the nurses wanted to come to our intensive care unit. First of all, you had the burnt out nurses in his big intensive care unit who'd had enough of this, working double shifts and so on, and who really wanted to come to a place where at least the patients were young and reasonably healthy before the whole episode started. So they wanted to come, and they were often very, very competent intensive care nurses, just wanted a bit of a rest. You also had the juniors who wanted to come because they were going to be taught by the midwives how to do OB as well, not just to do intensive care. So really, from the nurses' point of view, this was a great opportunity. The oncology nurses wanted to come because they could do their usual things, the chemotherapy and so on, but they could now learn some intensive care skills. And they now had a little badge that said that they were intensive care oncology nurses. So really, I think the choice of nurses is very, very important. Dr. Tara also mentioned another, I think, very important point, and that is the issue of obstetric medicine. The one thing that is exploding currently, at least on the US, the UK, and the Australian scene, is this new breed of animal called an obstetric medicine physician. And they're very useful people to have. Most hospitals will only have 1, or perhaps 2 if they're lucky, and perhaps 1 registrar or 1 trainee. So it's a very small department. But they actually produce the bridge between the obstetricians, the high-risk obstetricians, and then the intensive care units. I think that they're very useful people to have, and I see that only recently at the new Fernandez Hospital, Dr. Nelson Piercy was here, and she's, of course, like Michael De Sweet, one of the quintessential obstetric medicine specialists. So, you know, you do have the expertise here, and certainly it would be lovely to see this continuing, this trend of having obstetric intensive care units, but also with obstetric medicine and decent nursing.
Okay. Now I again shift focus, and we come to you, Chan. Do you think we should be teaching the warning signals or what? Because I was talking to you and you said that most of the time in an intensive care, we are just managing things what other people have missed. Something has gone wrong because somebody was not aware of it and finally lands up in an ICU and your mortality rate goes up. What do you think about it? How do you think we should go about it?
Well, the thing is, most of the time, if you look at any intensive care, I'm not just limiting it to obstetric intensive care, in a lot of intensive care, the outcome is such that the mortality may be averaging around 30%. In fact, if you have the money and you want to start a company, would you start a company called intensive care?
Absolutely.
Really? There's no profit.
And you could have him on board.
It drains your budget. So the thing is, I, in fact, am one of those who feel that we should put in a lot more time and a lot more effort in educating our frontline so that they don't mess up, so that they present to you patients that are at a stage where things can still be reversed. So, in fact, if you do that, I think you will be able to actually have a very much lower mortality rate amongst your patients who present as, patients who are under life threats. So, go out, put some, even if you don't believe in this, at least put a little bit of your time and effort in changing the landscape at the front line. And who are at the front line? Your juniors and the obstetrician. So if you can reach and educate at least one of them every day, turn them around, make sure they realize what hypoxia is all about, make sure that they know what a life threat is all about. In fact, at the present moment, I'm trying to actually make every obstetrician who comes and refers a fetal distress to me, that they must tell me whether it's in urgency level 1, 2, or 3. If you don't know how to classify, I say, what is the key word in level 1? Life threat. What is the key word in level 2? Compromise. What is the key word in level 3? Urgent, no compromise. So when you can actually differentiate the categories of patients, then, and establish your line of communication, then you can actually very clearly see and train your frontline doctors as to recognize what a life threat is all about. Once they can do that, they will do the right thing, and they won't allow the patient to degenerate to a stage where they need intensive care, where the outcome is usually very abysmal.
YK has missed one thing, that an educated obstetrician is an oxymoron. It's a bit like military intelligence or a fun run, It's,
Anybody who doesn't agree to what he said?
No, I think she makes a very important point.
Okay.
May I just make a
yes,
comment
please.
over here? When we are actually training our frontline people, as Dr. Chan said, it is very important to teach them exactly when they should initiate the process for discussion and transfer. Because very often with the HDUs, they are neither ICUs and they have degenerated even to the skills of HDUs, and then they transfer the patients. They have tried some skills at semi-HDU treatment, worsen the condition, patient reaches us even worse than it would have if it had been on the ward floor rather than in an HDU.
Pankaj, do you want to add anything?
I think we have made a beginning. Not now, almost 15 years back. The gynae or the obs postgraduates, first year when they take admission into the department for the post-graduation course, they are posted in Department of Anesthesia for 1 month, out of which 15 days they spend in the intensive care. And similarly, our residents also rotate in these branches so that they can also recognize what the potential problems are. If you train them raw, if you put the right perspective into their mind when they have just taken admission into the course, they are less likely to be poisoned later, because that concept forms in them and then it carries on for a little while. I can't say that it really transforms when they become graduates, but it does have an impact. At least we show them what they need to do, and we have a sigh of relief at times when they have managed, given oxygen, propped the patient up, attached the oximeter, put the leads on, and then tell us, sir, the patient has creps, please have a look at it.
Right, I think Pankaj has made a point, but being in anesthesia, I would add to it. I would really and sincerely hope we could get every branch of surgery posted to our department. Cardiothoracic surgeons, sick of them, they would know what anesthesia is all about. Urologists, pediatric surgeons, everybody. And obstetricians are no exception. So if you could get that, and the first, let's say, you could have a rotation program in the first 6 months of a 3-year, 4-year residency program, where anesthesia becomes equally important in these fields, I think it will go a long way. Do you agree to it, Pankaj? Yes, sir.
Can I add another point?
Yeah.
The other concept which has catched up because of the NTTC program which we run in JIPMA is the modular teaching. There are certain topics in obstetrics and in anesthesia where teachers or we can hold seminars, hold a module, let's say obstetric hemorrhage. What does the obstetrician think of it? What does a transfusion medicine person thinks of it? And what does an anesthetist think of it? Have all three of them speak to the postgraduates. So that's a modular teaching which has to come up on certain topics which we have to identify and inculcate this process of teaching into the postgraduate system.
Right, sir.
Can I, actually, if you ask me why a patient dies, from an organizational point of view, there are actually only three reasons. One is the provider has failed to recognize. Second, the provider has failed to do the correct thing. And lastly, the provider has failed to call for help. Because
the fourth one is the heart stops.
Because when you have a sick patient, the level of care is very high. And if you, as a provider, is not well trained, your level of care is just very far below. If you don't match the needs of the patient is going to have this gap in care that will ultimately kill her. So it's very important, as our panel has also said, the important thing is to teach your providers to recognize the ability to call so that the correct level of care can be brought to bear will save the patient. We're not training, in fact, we don't want to teach obstetrician anesthesiology, otherwise we'll be out of a job. So the important thing is to actually get them to recognize that they don't know, they need to call for help. Because I think every database, every report on mortality will urge providers, these are the lessons to be learned about mortality. Just call for help and call early.
I think, thank you. You've really hit the nail on the head. That's what is really important. Can I come back to you guys? If somebody wants to make a comment, why can't you join us? Tell us something. Yes, please. Yes, ma'am. Okay, first, it's something about obstetric medicine. First, let us know, would a lot of people who've done their post-graduation in obs and gynae opt to become an obstetric medicine chap? It is financially better or not better?
No, sir.
No.
I don't think anybody would opt obstetric medicine among the OBGYN group unless you have a passion for it, and the passion for the high-risk mothers and medical disorders complicating pregnancy, where when I see patients about 100, I know that I can do justice only to those medical problems, not the low risk, there is somebody else who's catering. So people, when they ask me, 16 years you have been doing this, don't you get vexed? I don't, sir. You should have the passion and then the determination to see this group as separate and they practice only this. But I don't know, probably in future in India it comes.
Right. Now, Raj, yes.
Can I just talk about the obstetric physician as well again? I think the anesthesiologist would make a very good obstetric physician. Because you see, while we are actually also into the field of anesthesia, we are actually providing the practical skills to manage the patient. If we actually have a passion, we would actually know a lot more about medicine and be able to actually meet the needs of the patient all the way from physiology, pharmacology, to medicine itself, to also having the clinical anesthetic skills to manage. So I think ultimately, if this field is to develop, I think we would encourage more anesthesiologists themselves to actually further in this end. And because it is such a hot kind of a field, I'm sure we must probably be in demand and the pay will be high.
The question was actually to Sifan. The lady asked, what kind of a bridging would be there by an ops medicine chap between the intensivist or the anesthesia chap in intensive care and the obstetrician? You talked about the bridge.
First of all, I'll talk about the financials for a moment. I think that you can certainly make a living doing this. And remember that the obstetricians in the main are very good at what they do, but they're not very good at medicine. And I don't know what it's like over here. But in terms of medicine, some of them are a bit lacking. The second thing I'd like to say is that I'm very lucky in Australia, and you've worked at Westmead, so you understand this. But the kudos amongst anesthetists is enormous. We basically, in terms of numbers, we have 3 times the size of the surgical department, for example. more than twice the size of medicine, the whole of medicine, with all their endocrinologists and so on. We're also seen as being the acute care guys. So we run the intensive care units, we run anesthesia, we run the cardiac, and we're everywhere. Everybody says in Australia, you know, God is everywhere, but anesthesia is like God, you know, they also are everywhere. And it's true, we've got people with expertise in cardiac, we have people with expertise in neuro. It doesn't matter really which way you hit us as a department. We always have the experts to produce. So YK is very right in saying, you know, perhaps in obstetrics, perhaps we should take over the obstetric medicine functions. On the other hand, I think that obstetricians often need to offload onto somebody when the deficiency arises in medicine itself. And sometimes it's the boring things that we don't want to do anyway. You know, it's how do you manage not a diabetic patient, but a patient with very severe thyrotoxicosis, for example. Not necessarily in the hospital, but at home. And so these people are developing quite large practices dealing only with obstetric patients. And I think that that's where the bridge becomes very useful. I think that they actually live somewhere in that grey zone between the ignorance of the obstetrician and the absolute brilliance of the anaesthetist.
Can I just... In fact, those of you who attended yesterday's workshop, there was another God that was introduced. That's good oxygen delivery. Is one of the new religion that we are actually starting in our own department. But anyway, coming back to this breach and whether you really need an obstetric physician, you know, we don't have one, although I feel that I'm actually contributing to that role in a certain extent in our hospital. But most of the high-risk patients who need care in a very major way, we actually team together all the providers from the hospital. That's the obstetrician who actually owns the patient. And then we come in and we also get extra physicians. Like, for example, the most recent one, we actually had a mother who, after the delivery, had severe bleeding and went on to have very raised liver enzymes. And we were quite afraid that, you know, she would go on to develop encephalopathy. So we actually got the gastroenterologist in with liver knowledge as well, so that, you know, we actually had a kind of twice daily discussion about the progress of the patient and what to do, whether to transfer her ultimately to the liver unit away in the another part of the city. So that actually helps a lot in the sense that you feel very comforted that, you know, there's this expertise that's come together on a regular basis and look at all the issues that are threatening her life, and then hoping that we collectively, with all the brains together, will be able to make the correct decision and the correct planning so that we don't miss out on the life threat that is slowly affecting her.
Right. Srinivas, you wanted
I just want to add a different perspective to this discussion. When you talk about obstetric medicine, I'm not an obstetric medicine expert, but when you spend 3 years of your professional life getting trained in obstetrics, I believe you are learning internal medicine, you're learning surgery, you're learning pulmonology, a little bit of nephrology, you're learning hematology and infectious diseases at the end of your 3 years of postgraduate training. So it's easier, I feel, for an obstetrician to graduate into obstetric medicine than for an anesthesiologist to learn internal medicine, pulmonology, and all this stuff over again. And for an obstetric medicine expert, it's not enough if you understand maternal physiology alone. You need to have an understanding of the maternal-fetal unit as an entity. And that, I believe, will happen better with an obstetrician rather than with a non-obstetrician graduating into obstetric medicine. This is purely my viewpoint.
Do you have, yes ma'am.
Can I say something?
Yeah, please.
One way to do things a bit expensively in hospitals is to use the team model. And I'll put on my hat as a hospital administrator and also as a health management fellow, and say that, you know, teams are great, but ultimately most hospitals are not run along those models. I think this is completely correct. That really it's a matter of finding certain types of people. This system doesn't have to be run by an obstetric medicine specialist. You can have a high-risk obstetrician, for example, or some guy who's seen as being one of the leaders in their units. It can be an anesthetist, it can be almost anybody. It does not have to be, and it can also be a high-risk obstetric team, except that the high-risk obstetric team is an expensive model of doing business, especially if your staff are already captured doing hundreds of seizures every day and seeing plenty of patients and so on. So I think the ideal is exactly what YK Chen is speaking about, where you have medicine, obstetrician, anesthetist, intensivist, all contributing to the care of one particular patient. But unfortunately, the structure is such that in very few countries, ours included, can you afford the luxury of dealing with almost all your high-risk patients using a team structure.
Right, thank you. Yes, lady. Yeah, please. Okay, fine. She has a comment to make that maybe a medicine chap would be better off.
I can answer that question. I am an internal medicine guy to begin with. The reason why...
Just a minute. You are an internal medicine guy. Interested in obstetric or not?
I am actually. I am actually...
I hope your wife is not an obstetrician.
My wife and my mother both are obstetricians.
Oh, then you are interested in that. Then it will be a biased answer, so let's not follow what he answers.
No,
yes, please.
That's got nothing to do with my viewpoint, which I expressed a short while ago, but I will answer that question. Majority of the guys who enter internal medicine, as Dr. Tarakeshwari said, some of us enter internal medicine with passion. We like the subject, we like the Harrison's textbook, so we take internal medicine. Good number of us choose to take internal medicine because we don't like surgery, right? We don't like to get into the scrubs and then deal with anesthesiologists day in and day out. So you are asking us, group of people who have ran away from surgery and operating rooms to go back into labor suits, to get into this kind of anesthesia-related issues. It's going to run into strife from day one. It's good that internal medicine guys can do obstetric medicine, but I still honestly feel an obstetrician is the right person to do obstetric.
Somebody who is a friend of his, just a minute, lady, there's a gentleman here. I would want this sentiment of his to be transferred to his house, to his mother, to his wife. Maybe he stays with us for the night today. He doesn't go back home. You can't have, right?
Actually, not so many people
Yes,
have the luxury of having a team already in the house itself. In fact, I actually remember very vividly how we actually had to struggle in this particular lady who was a Jehovah's Witness, and she had pulmonary hypertension. And I felt, although I had something like 25 years or so of obstetric anesthesia experience, this was an area that's, very far from what I normally manage. So in the end, I felt very lost as well. So I actually had to call quite a number of people, get the team. And what was strange was the fact that we actually felt comfort, when we discussed about the patient, and we felt that, we were not so lost. And we felt, we were actually seeking comfort with each other in our ignorance as to how to manage this particular patient. So I'm very sure there are areas where you don't really have any knowledge, even if you have been invested as an obstetric physician, that, there'll be areas that you have got very little experience in, and you would still relish getting a team to help you. And you will probably find that that's probably a better solution than thinking that one physician can be invested with enough knowledge to help everybody.
Right, thank you. I think we're going out of time, but we have a gentleman here. Maybe one last comment or a question. Yes, sir. I'll repeat it. Yeah, please.
2-3 minutes time I will take from the session. I would like to add one more point to what Madam Chen has said. 3 reasons why the patient died, by citing 2 examples. One more factor I am suggesting by citing 2 examples. One patient, young dentist, taken for emergency cesarean section, started bleeding. Immediately 3-4 transfusions were given, but there was no relief. Ultimately, factor 7A was given and bleeding stopped. In, again, post-operative ICU, she started bleeding here without wasting time. They gave again factor 7 and the bleeding stopped. After 43 days of stay, she was diagnosed to have Wilson's disease and discharged normally. But this is a scene of a military hospital where factor 7A was available. Whereas a place where I am working, 30 transfusions could not save the life because factor 7A was not available. Second scene is at a KM. This was reported in one of the obstetrics anesthesia conference. by a resident. She gave spinal by sensor cane and patient developed cardiac toxicity. There was no intralipid. Patient could not be saved. So this is the fourth point which I am saying. Even despite knowing the reason, we can have a problem because a thing is not available. Your comments, sir.
I think he's talked about something for which most of the credit or discredit goes to a politician, a hospital and financial chap. He talks about non-availability of expensive drugs or easy availability of blood vis-a-vis other kind of substitutes. I think, sir, this will have to be worked at an individual level. The place where you work, insurance companies, whatever social security systems. Does anybody want to make any comment regarding this? Availability of certain things which could save people, which are available in one setup, and they may not be available in the second setup.
When it comes to 7A, for example, you know, it's interesting to see that at Fernandez Hospital, I approached them about this, mainly because I'm talking about it tomorrow. And it's interesting, of course, because they're making it available to the poorest of the poor all the way up to, and they've set up their own mechanism as to how to do this. They've done it through the foundation, and so it works quite nicely over there. But remember that, in fact, most of these very expensive technologies, from a national point of view, are a tremendous waste in a lot of ways, because you can deliver a lot more care with a diabetic clinic, for example, with a nurse, in terms of saving people's lives, than you can by having a factor 7A service that's spending a lot of money on single. And remember, too, that sometimes the simplest methods are the ones that actually save lives. And I always say, keep something like factor 7A very much in perspective. And the perspective is this. The perspective is that, in fact, the massive transfusion protocol, for example, which costs absolutely nothing and probably has saved us many millions in saved blood, actually is a much more effective way of saving people's lives if the problem is bleeding than has factor 7A. Sure, as a country, we've used 6,000 plus ampoules of factor 7A, but in fact, a fair number of them have actually been wasted rather than actually being used. We have cardiac surgeons, for example, who give factor 7A not on a whim, but, you know, I think things are going to get worse, and this looks like a patient who might bleed, and we've only given 1 unit of blood so far, but let's give it a factor 7A and hope we don't have to come back. Now, there's actually some good reasoning behind this. It sounds a bit stupid to do, but in fact, if you bring a cardiac patient back for a redo, for example, it's going to cost you much more than factor 7A. So, you know, you need to temper the high-risk technologies. It is very, very rare that patients die because of the lack of a high-risk technology. Sure, the mortality overall might improve if you use it. In fact, in some situations, it might actually cost you less in the long run to use some expensive technologies. And we see this every day. You know, the lap choles are now being done laparoscopically, and they stay in hospital for 12 hours or less, rather than having them in for 10 days. So medicine is interesting, you know, in this respect. You know, there are often, and I'm sure you've all read one of your compatriots' books from Arul Gawande, for example, you know, and what he has to say about expensive technologies. I guess you get the message that I think that expensive technologies are nice to have, especially if you live in intensive care. You know, it's lovely to have protein C, it's lovely to have factor 7A, it's lovely to have all those things. But often they get given to the patients who need it the least. They are the terminal 85-year-olds who are going to die anyway in the first place. So really, if you want to use technologies like this, I would reserve them very much for the people who need them and for the people who will get a benefit long-term from them. And I think the obstetric population is very much like this. So one of my great incentives has always been to try and convince governments that your obstetric population is really worth putting money into. You know, a family without a mum who's died from childbirth is an absolute disaster. You suddenly have 5, 6 people who can't rely on somebody to feed them every day. So in fact, it's actually a very inexpensive arrangement to actually save a life in that kind of situation that the gentleman has just put up to us.
Right, thank you very much. I think, yes, the last comment.
Can I just extend the education pool of people we need to educate? We need to educate the administrators. In fact, when we feel, and we have the evidence, like what Steve was saying this morning, when you collect your near-miss audit and all that, use this as evidence to actually tell your administrators what needs to be done. Because administrators are not very tuned to what we're actually doing. Most of the time when they conduct discussions about deaths and all that, the lessons are never transmitted to the correct people. So what we need to do is to educate these administrators. And what we have learned, like from the conference, that intralipid is now generally accepted as being important in any area where local anesthetics are administered. So make sure that if you cannot do it, tell your head of department or tell your administrators, make it available. Tell the pharmacists, just give it to us and we'll put it to where, in an area where it's needed half the time. So we have to change the administrators because most of the time they don't know what they need to do.
I think, thank you very much. We end on this note. We change the administrators. My suggestion is don't try to do it, he'll change you. No, you don't change an administrator. You toe his line. I've just noted down some carry-home messages, which I think I'll summarize and then we come to a close. We've really come to a conclusion that it's worthwhile having a single ICU, no matter if Stephen decides to set up one again if the government pays him money. But in today's scenarios, in the corporate world, it's financially more effective to have a single ICU, which could be having many more beds, and then you could staff it, than to have ICU which is dedicated to one, let's say, obstetric unit. The second thing is, what Chan said, training the first-line people would be very important so that we can take care of mothers, we can take care of the population which comes to the ICU who are really being not managed well, and we pick them early. Third one, the obstetric medicine. Well, it's the incoming thing what most of our panelists feel. If somebody is not making good money in anesthesia, you could decide to shift over to ops medicine, and I'm sure you could find a job. And lastly, I think Chan has given you a very nice idea to think about it. You go home, float a company named an ICU company, and you have two directors, Chan and Stephen, into it, and they would do wonders. Thank you very much. I thank all the panelists, Dr. Stephen Gatt, Dr. Y.K. Chan, Dr. Prithvish Bhattacharya, Srinivas Samavadan, and Tarakeshwari. Thank you very much, sirs and madam. I think we have had an excellent session, and we hope to have you again. Let's give them a big hand.